So should we follow the same format? I mean, Adam and Pam, you've introduced yourselves, but maybe if David, if you'd like to introduce yourself, and then we'll questions.
Yeah, okay, sure. I'm actually David Healy, and I work in Wales. And I'm here for an odd reason, really, which is years ago when the fuss about these drugs blew up, I drew up a very brief protocol about how to get off them. In actual fact, I just took the protocol that we use for trying to get people off, say, drugs like the benzodiazepines, and moved it over to the SSRIs. It's probably the case that there's people here in the room who know more about how to get off these drugs than I do. Let's frame that slightly differently. I hear from loads and loads of people who have problems trying to get off the drugs, and they've gone through the protocol, or they've done all the usual things to try and get off the drugs, and they don't seem to be able to, okay? I've asked loads and loads of people what we can do for anyone who's actually finding it hard to get off the drugs. And the conclusion I've come to is that it can be awfully hard to do, and that for a proportion of people there may not be any answers. So I've come here partly to try and see if you guys have any answers. One of the problems we've got is you may have come here wondering if I have any answers, so we both have to share this problem, okay?
Okay, so do you want to add anything to that, or should we just start taking
Only
contributions?
2 agrees.
Right, okay.
We need to pool our resources.
Right, so are there any contributions, Catherine?
Well, a psychologist from Shropshire, he was helping his clients come off psychoactive drugs, and the best way that he thought was to, well, from experience, was to only do one drug at a time, and leave the benzodiazepines till last. And he didn't mention SSRI, I don't know where they come from. And having tried to withdraw a benzo and a neuroleptic at the same time, and we did go askew, I would go along with that.
I think that makes sense,
Yeah.
yes.
I mean, that's one of my golden rules, never ever withdraw 2 drugs at once. I mean, the rule used to be that when we were dealing with tricyclics, that you would do the benzo first on the rationale that the tricyclic would then keep the nervous system stable while you did the reduction. Since SSRIs have come in, that is less clear cut, because very often if the patient comes off the benzo first, then does the SSRI, they then become very anxious in the withdrawal and want to resort back to the benzo. So it's more of a problem which to do first, and I'm inclined to think very often it's better to do it the other way around when you're dealing with SSRIs. But I think it's important that yes, their preference is taken into consideration, but that they also do that from a clued up point of view, knowing what doing one first and then the other is going to entail, and what difficulties they may have if they choose to do it one way rather than the other. I think that's true across the board anyway with the whole subject.
There was another question at the back there.
They cause problems in that, as was mentioned earlier, some people lack an enzyme in the liver which enables them to deal with the SSRI. And then this may lead to problems and may mean that alcohol, for instance, isn't as adequately dealt with because the liver's too busy desperately trying to deal with the SSRI. And it may also lead to really bizarre and very, very acute reactions to the SSRI. I mean, David may want to say something about that.
Sure. It's just I was actually thinking about a completely different issue. Well,
Sorry.
Sorry.
The point I wanted to ask was if these drugs slow down the action of the liver and they kind of can build up to a toxic sort of level and cause problems.
Well, I don't think that's what leads to you being hooked to them.
Not hooked, no, but causing problems. Things like St John's wort actually speed up the process of the liver, and I'm wondering if there's been any research with use of things like St John's wort as a replacement to clear the body and get the person on a more stable footing again.
In terms of trying to alleviate the side effects that maybe the SSRIs can cause, part of the problem, I guess, is that St John's wort itself also actually acts in a bit the same way. So it can cause all of the problems that the SSRIs can cause. So there's a group of people who say that do reasonably well on, say, the SSRIs, and they can change over to St. John's wort and report just the same good things from it as they get from drugs like Prozac. And then there are people who do awfully poorly on the SSRIs, and when they change over to St. John's wort, they report all the problems on it that they've had with drugs like Prozac. So it's not absolutely simple. If we could just sort of move kind of the active drug out and move St. John's wort in, that would be fine, but it's not always that easy.
I'm a research psychologist from Cambridge, and I'm linked to a group in Cambridge called CAMS, Coping with Coming Off, which runs support groups for service users thinking about medication. And my question is for Adam, really. I've noticed in your details that you run self-help groups talking about these issues, and I wondered if you could share with us some of your experience of particularly how the peer support works, and just how you run those groups, really.
We ran a group for a while in Hebden Bridge called Coming Off. We kind of changed it. I was just telling someone a minute ago. We changed it. The name of the group's changed because people wanted to change it. And B, it's called Psych Medicine New. And one of the reasons we did that is that some people who came to the group weren't in a place where they could come off, where they felt the obstacles were too many and that they needed some more time. And those people found it difficult coming to a group that was about coming off because, it's like the goal was to come off. So we've kind of changed it. We have very few rules. We kind of run them the same way that we run all the self-help groups, which is similar to Hearing Voices, which is that there's no one wisdom, that we all have wisdom. Truth has many faces, there are many versions of the truth, and I've got a copy of the ground rules that we had. One was about confidentiality, so what we kind of run in the group stays in the group, although we did agree that it might be beneficial to share stories outside of the group, but not the personal information. So it might be good to tell other people, well, actually I found getting to sleep using certain herbs was better for me, and we sort of thought about that. There was a mutual respect for individuals' opinions, beliefs, ideas, and the other thing was that we kind of had one person speaking at a time. The two aims to the group were kind of to share information about ways to reduce or come off psychiatric meds, and to share ideas about alternative ways to live with what's happening. We kind of ran the groups on the premise that these experiences have their root in our life histories, not really in brain chemistry. Sure, brain chemistry has some play in that, but we need to look at other ways forward. We always said that the responsibility for what people do with the medication stays with the individual. It's not the group's responsibility really to decide that. To give you a bit of an idea about what we did for the format of the group, we might start with a technique that might help. So, for example, someone might bring a breathing exercise to the group and we'd all have a go at the breathing exercise, or we might talk about a particular therapy that might be useful. Say for voices, we were talking about a technique that's kind of getting a lot of motion called voice dialogue, talking with voices. We might do meditation or do a bit of drama, and kind of just show people the different ways that they can deal with things. After that, we kind of spend a bit of time going round and just seeing where everybody was at in terms of their week, what was happening with them, what was happening with medication, where did they see themselves, and there'd be a bit of a break there, and then afterwards we would kind of maybe review some of the information that we have around a particular drug or type of drug. So borrowing from John as well, and kind of just leave it like that really. We did occasionally, we have supported one or two people outside of the group who were in hospital and finding it difficult to have those conversations with professionals, but generally that's how the group runs. Is that
Do you want to say something about the Icarus Project guidelines? Yeah.
Yeah,
Do you want some copies?
I have. I've brought this. This is available on our website, comingoff.com. Imagine it in the title, so you can download it. But this is a harm reduction guide by an American project called the Icarus Project. I think it's really good. It's really quite informative, and it kind of takes you through kind of looking at how you might view your experiences. You know, how you might understand them, to whether you want to come off of psychiatric drugs, and ways of thinking about that. And there is a harm reduction thing about if you want to stay on psychiatric drugs, things that you might be able to do that might help as well, like maybe lowering the dose and things like that. So there are copies here which feel free to take, because I've kind of brought them for that reason. But if they've all gone, you can access it on our website, comingoff.com.
Does that mention dietary advice? Because I'm quite into that recently.
Yeah,
Find
it
that,
does.
if people stay on these drugs, it's quite useful to have advice to do with diet, which will help them.
Yeah, it's quite
That's very useful. And the website comingoff.com, if everyone isn't familiar with it, is also a brilliant website. Adam's been involved in setting it up, and Rufus May. And there's lots of stories of people who've successfully come off or reduced, which I think is quite encouraging, and lots of information, plus you can download those guidelines. So I'd really encourage people to look at it.
If you've got stories of coming off or trying to come off, then if you'd like to add them there, that'd be great as well. You know, you add to people's experiences, and you can contact us through the website as well. So
Can I just ask the room a question? Are there people in the room who just aren't able to come off these things at all? Yeah. Because I think all these things are helpful, but I think we probably need to recognise that we don't know what's involved in the withdrawal syndrome. We don't know how many people just aren't able to come off at all, and you could really end up in a bit of a pickle if you think you should be able to come off and go at it in a very kind of determined way and find you can't.
And I think we don't really know why they can't come off, do we?
No.
We don't really know what the mechanism
I
is.
think that's the importance of planning, you know, so you have kind of backup plans, right, if you're not able to do this. And that's why we changed the name of the group, because we don't want people to feel that they failed in some way by ending up in that situation. But, you know, it is a very difficult process. We've noticed that the longer that people spend on these drugs, the harder it is to get off. You know, and if you can, if anyone's involved in it, make sure that they stay on the lowest dose possible right from the start, if they even have to use them, you know.
Before I take more contributions.
Do you want to come?
Okay. Quickly, I think there's a middle ground that's probably important. If you say that we sort of ought to use the pills, that there are real illnesses there that the pills treat, and if you have problems when you halt your pills, this is just the, you know, what we actually see is just the illness come back, then you aren't going to sort of learn the kinds of things that we could learn from the pills, which is that within, say, the antipsychotics, there are ones that do cause withdrawal problems more often than sort of drugs in the group that seem that seem to be probably less likely to cause problems. Within, say, the antidepressant group, there are drugs that are worse, and there are drugs that aren't as bad. If you take the view that the pills shouldn't be used at all, you again end up not knowing, are there good drugs, bad drugs? A thing that I think we probably need to learn, those of us who aren't at the extreme, is just to keep a close eye on the pills and see if there are ones that are worse than say the others, and if so, why? Because we don't, I think we don't actually know which pills are